I am Dr. Ifatara, intern doctor of Boshundhara Adin Medical College and Hospital. Today in this foggy winter morning, I welcome you all for the monthly CME program. Our today topic is correction of Equinus deformity by Ilizarov procedure will be presented by Orthopedic Department of Boshundhara Adin Medical College and Hospital. Now, please have your seat, and I request our special guest, Professor Dr. Rifat Tabassu ma'am, and Associate Professor Atikur Rahman sir, to take their seat. And now I am request our chief guest, Professor Dr. Mohammad Ruhul Amin sir, and our chairperson, Professor Dr. Mohammad Ghulam Rahman Dulal sir, to take their seat. Now I am requesting our associate professor, Dr. Mahmudur Rahman Imrul sir, to come on dais and present today's case. Thank you.
Principal of Boshundhara Adin Medical College, Professor Dr. Ghulam Rahman sir, Honorable Chief Guest, Director of Boshundhara Adin Medical College, Professor Dr. Ruhul Amin sir, respected teachers, dear colleagues and my dear students, Assalamu alaikum. Welcome you all in today's CME, and today's CME is organized by the Department of Orthopedics, Boshundhara Adin Medical College. The topic that has been selected for today's discussion is correction of Equinus deformity of foot by Ilizarov external fixator at Boshundhara Adin Medical College. First of all, we will go through some overview of this Equinus deformity. Then we will learn something about Ilizarov external fixator, and then we will show our case that we have did in our college. This is the basic ankle, foot and anatomy. We already know about these things from the beginning of our medical life. That is, the ankle joint shows different bones and ligaments around it, and ankle joint produces the dorsiflexion and plantar flexion movement, and there also have some movement of the subtalar joint and foot. And now, what is the Equinus deformity? In Latin, equina means horse. Equinus foot deformity is a condition that causes limited ankle joint movement, where the foot is in plantar flexed position and dorsiflexion of the foot is limited or restricted. In this deformity, actually some foot movement or ankle movement is limited or restricted. That is, when this Equinus deformity occur, difficulty will occur also in walking, running, upsteering, downsteering in these cases. And here we can show that there is the dorsiflexion and plantar flexion movement of the joint, but in case of Equinus deformity, this dorsiflexion is completely restricted. If you classify this congenital deformity, Equinus deformity, basically this is of two types. One is the congenital and another is acquired. This congenital deformity or Equinus deformity is usually associated with other congenital deformities like congenital talipes equinovarus deformity, congenital vertical talus, or congenital hallux valgus deformity. And acquired deformity is usually in adult traumatic, and according to severity, this may be mild, moderate, severe according to degree. Mild may be less than 20 degree, moderate 20 to 40 degree, and if it is more than 40 degree, we can consider it severe. And in epidemiology, the incidence common foot deformity is seen with cerebral palsy, and this is the most common scenario of Equinus deformity, and it usually present with other deformities of the both lower limb and upper limbs, and usually this is of spastic type, Duchenne muscular dystrophy and residual clubfoot deformity. And what is that? After treatment of clubfoot, few deformities are corrected, but the Equinus deformity still remain, or recurrence of this Equinus deformity may occur, and this may be associated with the spina bifida and tibial deficiency. Okay. And etiology: congenital contracture or shortening of the Achilles tendon, anterior ankle bone block, posterior ankle contracture. It means there is some posterior structure in the ankle joint like ligaments, tibialis posterior tendon, peroneus tendon, and tendoachilles, and ligaments, posterior capsular ligament, and there is a tightening of these soft tissues which produces the equinus deformity of the foot. And congenital posterior ankle or tendoachilles contracture, that means both the elements are involved in here. And acquired cases: injury to cause scarring of the Achilles tendon or posterior ankle structure, and this thing is acquired or due to injury to the ankle that results in an anterior ankle block, posterior ankle contracture secondary to drop foot or arthritis of the ankle joint. And what are the presentation of equinus deformity? The symptoms are difficulty in walking, running, jumping, up and down staring, and sometimes this may be painful. Painful weight bearing on the forefoot may be associated with some instability in few cases, and there is a difficulty in shoe wearing or wearing the brace, etc. In physical examination, in look you can see the foot is in plantar flexed position, and there may be wasting of the leg and foot muscle, and hip and knee may be in flexed position. In this image you can see one is from the lateral side, one from the medial side. In both the cases foot is in equinus position and there is some flexion of the knee joint. And in physical examination, if you examine the patient in supine position, the tendoachilles will feel cord-like and that is tight. Ankle range of motion may be restricted according to the severity, and in case of upper motor neuron lesion or if it is due to some neurological cause, ankle jerk, plantar response or clonus may be present in some cases. And we should do some radiological investigation for the searching the cause of this equinus deformity. We can do X-ray, and another is the 3D CT scan, and both these help us to evaluate or find out the any bony or soft tissue pathologies. And now the treatment is mainly based on the cause of this equinus deformity and severity of the equinus deformity. We have also have the opportunity to do some non-operative treatment as well as operative treatment. Non-operative treatment includes ankle foot orthosis, and we can use this in case of flexible cases where still the rigidity is not present. This helps provide stability for the foot and a more stable base of support during gait. And we can also do serial plaster. Serial plaster we can do when the bone is not still matured or more young age, less than 3-4 years. In that case the bones are still soft or malleable. In that case serial casting can help us to correct this equinus deformity. And another thing, we can give botulinum toxin in case of equinus deformity where the muscle tightness or muscle spasticity is the cause. Indication: flexible and dynamic deformity or desire to delay surgery. An operative treatment for equinus deformity, we can sometimes we can do gastrocnemius resection or tendoachilles lengthening. Indication: fixed equinus unresponsive to non-operative measures. And now the main topic, what is today we are discussing about, that is the Ilizarov procedure. The Ilizarov method is one of the current methods used in bone reconstruction. It comprises a number of bone reconstruction techniques performed with a ring external fixator developed by Gabriel Abramovich Ilizarov in 1951 in former Soviet And these are the different types of apparatus showing here to correct the deformities or helps to reconstruction of the bone. And what are the indication of using Ilizarov for the correction of equinus deformity? One is the failed conservative management, rigid form of equinus. The Ilizarov external fixator is a valuable tool to correct complex foot deformities with limb length discrepancy and joint contracture. It allows preservation of foot size or lengthening of a baseline shortened foot. It allows correction of it allows correction by slow distraction with lower complication rate. In severe case where the equinus deformity is more than 40 degree, corrected gradually by this procedure is possible. And now the case, our patient was Abu Naim, a boy of 10 years old from Bhola. His complaint was equinus deformity of his right foot for 1 year and shortening and limping gait with right lower limb for the same duration. This boy had a history of fall from height about 1 year back. Then he was reported to then the patient was unable to stand and walk with his right lower limb, and then he was reported to local hospital, and there he was diagnosed as a case of fractured neck of femur. And after that, in that hospital, surface traction was applied by local paramedic staff, and after 48 hours of application of this surface traction, patient developed compartment syndrome, and which causes necrosis of the muscle, and where the muscle was replaced by scar or fibrous tissue, and subsequently there is a shortening of the posterior muscles of the posterior compartments of the leg, and which produces the Volkmann's ischemic contracture, and for that reason patient lost his contractile capacity of the leg muscles, and finally it develops a rigid and stiff ankle joint in equinus position. And this is the clinical photo of the patient right foot, showing there is the equinus deformity of the foot. And all other parameters of the patient, including general examination and system examination, everything reveals normal, no abnormality was found. And in local examination, in standing position, shortening of the right lower limb was present, wasting of the leg and foot muscle, and equinus deformity of foot was present. And in here you can see there is the equinus deformity of the foot, and wasting was present both in the leg muscle and the foot, and shortening of the leg of about 2 centimeter, and equinus deformity, the range of motion is 150 degree to 170 degree. Okay. This is the X-ray showing the foot is in completely in equinus position. So treatment option for this case, first serial plaster, as it is a very rigid variety. For this patient, serial plaster will not be applicable. And surgery, soft tissue surgery, then soft tissue surgery as well associated with bony procedure. But this surgery sometimes end up with some ugly scars, painful joints, delayed soft tissue healing, and chance of infection is very high. So we chose the method that is the gradual correction of equinus deformity by Ilizarov external fixator. And we applied Ilizarov external fixator in his foot. And this is the post-operative image after application of Ilizarov external fixator. Actually, this image looks very crowdy, lot of apparatus around the foot, but actually inside the bone there is very few things. So one ring is in the middle of the leg, another ring is just 2 to 3 centimeter above the ankle joint. This ring was applied by giving only 2 K wires at that level, and another 2 K wires in this level, and 2 K wire in this level, and 2 K wire. Only 8 thin pin is inside the body. In total 8 pins are inside the body, but all the rest of the things are outside. and these two ring in his hair in the leg portion, and one U ring is in the foot, and there is a hinge in here. Okay, and this technique is very simple. We applied a rod in here and another rod is applied in here. The simple thing is gradually we shortening this rod and gradually we increasing the length of this rod. So subsequently the foot deformity is gradually corrected, the equinus foot is gradually corrected into its normal plantigrade position. And this is the medial side view of the clinical photo of the patient. This is the two rings in the leg, and this is the U ring, and this is the hinge in the medial side, and this is the posterior rod. This will be lengthened gradually, and this is the anterior rod. This is shortened gradually, and the procedure is to 1 millimeter lengthening or shortening per day, and it is divided into 4 parts. That means only 0.25 millimeter every 6 hours. So gradually and very slowly correction of the deformity gives the patient painless correction of the foot. And this is from the view from the top, and this is the X-ray. So you can see all the apparatus is outside the limb, only these thin wires are inside the body. So actually this is less painful than doing surgery or open procedure. And this is the image after gradual correction after 6 months. Here you can see the foot is in plantigrade position. In the lateral view, foot is in plantigrade position or normal anatomical position of the foot. And this is the X-ray showing, if you compare the old X-ray, the X-ray shows the foot is in plantigrade or normal anatomical position. And this is the image after removal of the external fixator. No scar mark, only pin track site, small ulcerated area, and this will be healed within 7 days actually. And this is the comparison between the preoperative and postoperative image of the patient foot. Here it looks straight, there is equinus deformity, and this is the image after correction of the foot deformity. And initially you have to apply a short leg cast during walking to prevent recurrence. This is the image video after removal of the external fixator. Patient is walking very nicely. And this is the another image from the back. Patient is walking very nicely and it is painless, and here some limping gait is present. And why this limping gait is present, that is patient already we told that there is a fracture in the neck of the femur. So there is a shortening of the limb, and that is why his limping gait is present now. And after his maturation of the bone at the age of 18 or 20 years, patient may need a further surgery, or even after 2 to 3 years, if patients allow, we may need to go for a corrective osteotomy at the trochanteric region, which helps to correct the shortening of the limb. And there is a very minimum chance of complication in case of Ilizarov surgery, like pin track infection, nerve injury, and in this case there is a particularly there is a subluxation of the ankle joint, but minimum pin track infection was present, that we can consider it as a no complication. There was no nerve injury and there was no subluxation of the ankle joint in our case. And patient need follow up for up to 2 to 3 years to prevent a recurrence. With this I conclude. Thank you. Thanks to you all. Assalamu alaikum.
Now I request our chairperson, Professor Dr. Gholam Rahman Dulal sir, to give your valuable speech.
Other teachers, junior teachers, and my beloved student, especially first year and fifth year. Today we are third time we started here as a CME programs. Previously, we know the CME in which way happened in our medical college and hospitals. But after taking the responsibility of me, I decided all should be changed, and it should be like a tertiary level hospitals. We always think like that. But to continue this needs supports from every departments. I think that by this time all of the departments are agree with me to continue here, which I wanted as a legal or authentic way to continue. Secondly, I give a thanks lot to Dr. Imrul, who is my junior colleagues. He is performing here a lot of cases, but the publication is to pupils, to doctors, and to localities very, very poor. I think that it should be need to overcome now. I request to Dr. Imrul, you are not present as a hidden persons. So far my knowledge, you are more meritorious than me, as well as you are more devoted to your topics. And we are lucky here that this type of specialist, not only as a general surgeons, as orthopedic surgeon, you are disclosing here. I always help to you. Now I want to say a few words regarding Elizarov's. This is a big history. If I tell some things about this history, this Ilizarov is not a instruments or not implants. It is the name of one person, and the full name of that person is Professor Ilizarov Gabriel Abramovich Ilizarov. Is returned at the time of Second World War at his own country, and also his own person is suspected the complex fractures. At 1950, he is thinking about something. Those who are suffering is a long case of non-unions, especially tibia or other bones. At 1954, he was applying to a patient, and the patient is also a factory workers and suffering for a long time of non-union of the lower tibia as well as significant limb length discrepancy. After that, 1964, the world champion, Olympic champions, Brummel, is sufferer for a long time, non-union of the lower tibia, including infections, as well as significant shortening of the bone. This Brummel man, he is the champion at Olympic as a high jumper. At the 1964, that man is visited to the Ilizarov at the Russia. 1968, after visiting, he interested to receive the treatments. After giving the treatment of that person, that is to the players, the outcome is so nice and rapidly happen. Whole of the Russia as well as the whole of the world is known about this new idea. At that time, the governments of the Russia also declared it will be established in their country. And the place of their name is Kurgan, Russia, Soviet Union, that is it previously. After that, again few players from Italy received the treatments, but very fantastic and interesting that the Olympic jumpers men 3 years sufferers as infected non-unions, and within the 3 years 20 times are operated done by orthopedic surgeon and all are failed. So one player or one actors can be established anytimes, anywhere, if he or she is supported to the institutes. On the other hand, after that, we are seeing that this Ilizarov is now the new technique, new idea. By this time we are seeing here, where all of the generals, orthopedic surgeons are failed to what we manage, in which way I manage to the patients. Nowadays, our hope that where we fail as a surgeons, the Ilizarov is our answers. We are uses it everywhere, not only bone, and in bone it is nowadays used not only non-union but also at the early union. Fresh cases, bone lengthening where more than 2 centimeters is usually needed. You know that in RTA sometimes bone loss is present in open fractures. In open fracture usually we are not intramedullary or internally can use any implants. So this is one of our latest good answers. Another external fixator is also present, that is known as uniaxial, which is acting only 90-degree angle, biaxial, which is acting only 180-degree angles. And this Ilizarov has like an MRI machine, MRI films, CT scan films, where this acting 360-degree angles. So there is no chance of angulations after unions or others. You can angle it or correct it according to your wanted as anatomical way. Not only in bones we are nowadays applying, we are applying others musculoskeletal systems, as for example contractures. And latestly we are also applying the burn post-operative contractures. Just the method is, by this time we have learned that 1 millimeter we can release every times, that means every day. And worldwide, everywhere this Ilizarov hospitals as well as Ilizarov clinic is recognized also in our neighbor country, that is India. And in our country also this Ilizarov clinic is also present, and also we are mentioned that research that Bari Ilizarov hospitals, many of the doctors by this time you know, but a specialist or works only this is very few surgeons. Among them my surgeon is also one of this. So now need to help from you, and you can support it us as well as you can receive your patient also. Not only we are treated, Ilizarov is only for diseased person, but nowadays worldwide the main priority is coming or ongoing to higher height, that means those who are short stature persons normally physiologically, and this is mostly used in other country like Hong Kong, China, Thailand. And from my knowledge, I know that there in this country also have the university. They give us the opinion that to learn training here 1 year or 2 years. In our country, without disease, we are very short person can use this because of disoriented or publics are still now not know. So my students and other colleagues, I invited to you those who are interested to make a height at optimum level. You can receive our treatments. Thank you everyone. Thank you all of the doctors, all of the students. Thank you everyone.
ধন্যবাদ সবাইকে। চমৎকার একটা সিএমই প্রোগ্রাম আমরা দেখলাম এবং তারেক স্যারের কথা মতন আমিও এগ্রি করছি যে আমি আসলে ইলিজারভ নামটা আজকে ফার্স্ট শুনলাম। আমারও একটা কোয়েশ্চেন ছিল যে এজ লিমিটেশনের ব্যাপারটা, কারণ আমাদের দেশে অ্যাক্সিডেন্ট খুব কমন। এখানে যেই কেসটা দেখানো হয়েছে সেটা হচ্ছে 10 বছরের একটা বাচ্চা। তো 10 বছরের একটা বাচ্চা খেলতে যে ব্যথা পেতে পারে যেরকম, সেরকম একটা অ্যাডাল্ট মানুষও অ্যাক্সিডেন্টে, যেহেতু আমাদের দেশে এখন অনেক কমন। তো এটা শুনে আমি খুব রিলিভড হলাম যে এটার সাথে কোনো এজ বার নাই। এটা অবশ্যই খুব ভালো একটা প্রসিডিউর। অ্যাজ এ হোল প্লাস্টার এমন একটা মেথড যেটা দিনের পর দিন মানুষকে একেবারে মানে খুব প্রেশারাইজড করে রাখে, স্কিনটা ইয়ে হয়। তো আমার কাছে মনে হয়েছে আমি অনেক কিছু শিখলাম। আর সিএনই প্রোগ্রাম আমাদের এখানে এখন রেগুলারলি হবে ইনশাআল্লাহ, এবং আমাদের 2টা গ্যালারি এই কারণে রেডি করা হয়েছে। আমরা আশা করব যখন মানে কোনো একটা সিএনই প্রোগ্রাম হবে আমরা সবাই সেখানে অ্যাটেন্ড করার চেষ্টা করব ইনশাআল্লাহ। সবাইকে ধন্যবাদ।
Thank you, ma'am. Now I request our special guest, Professor Dr. Rifat Tabassum, ma'am.
আসসালামু আলাইকুম। আমাদের এখানে সেমিনার সিএমই যে প্রোগ্রামগুলো ছিল এগুলো অনেক আগে থেকে আসলে হয়েছিল, বাট ইরেগুলারলি হয়েছিল। বাট স্যার গোলামুর রহমান দুলাল স্যার আসার পর একটা অর্গানাইজড ওয়েতে এবং রেগুলার যাতে হয় সেটা অ্যারেঞ্জ আমরা করতে পেরেছি আলহামদুলিল্লাহ। স্যারকে অনেক অনেক ধন্যবাদ আমাদের এইভাবে সিএমই প্রোগ্রাম অ্যারেঞ্জ করার জন্য। আর আজকে আমি স্পেশালি থ্যাংক ইউ দিতে চাই ইমরুল স্যারকে যে এত সুন্দর একটা টপিক প্রেজেন্ট করার জন্য। অবশ্যই নিউ একটা টপিক যেটা সম্পর্কে আমরা আসলে আমি মনে হয় প্রি ক্লিনিক্যাল যারা আছি তাদের একটু কমই নলেজ আছে এই ব্যাপারে। থ্যাংক ইউ এগেইন। আর ইনশাআল্লাহ আমাদের সেমিনারগুলো রেগুলারলি হবে এবং আমরা আশা করব সবাই প্রেজেন্ট থাকবেন।
Thank you, ma'am. Now I am requesting our chief guest, Professor Dr. Mohammad Ruhul Amin sir, to give your valuable opinion.
Assalamu alaikum and very good morning to everybody. Honorable Chairperson and respected teachers, today's CME, I think, it brought all us together in a room to share our knowledge, to share our experience. I think CME is the life of the medical science. We are learning, always we are not learning. We are here to give the service to the patient, to the latest, with the latest technology. So we should gather the knowledge, we should update our knowledge. Some in the ancient times, what they did for the Equinus, I don't know. But today's technology, I think it is very easier and very acceptable to all. So patients, they will ensure, they will feel happy for their future. They can, those that are suffering from such diseases, they can enjoy their life, they can do something for their family, for the nation also. So I always welcome all of you to attend such a seminar to gather knowledge. And last of all, I give thanks to Dr. Mahmoud Imrul. I am feeling so happy and I am working with you all for the last 10 years. I am feeling very proud with you. I am telling to you what you are doing, you should publish it. Without publication, it is not known to all. When you publish it, then we get confidence. Confidence is very important. Very important. We are doing so many things in our daily practice, but it is not practiced. We are not published, so that another person is not known to that. During our practice, we face so many things. I can tell you one thing come about essential vapor spasm using of botulinum toxin. I also work with this during my dissertation. I do with doxorubicin. Doxorubicin causes fibrosis of the muscular fibers in the knee muscle. You know, in blepharospasm, there is a spasm of the leads by the auricular muscle. A spontaneous spasm, patient cannot look. But with the botulinum toxin, the treatment is temporary. It will work for 3 months. You should need repeated injection. Then ultimately there is no permanent solution. So I want to establish with another colleague, Dr. Professor Hagar, we started doxorubicin. You know, it is a carcinoma anti-cancer drug. With very low dose, we give it with multiple functions in the muscular layer. But complications is there is sometimes necrosis of the skin, disfiguration. Then we discontinue this. But we present it in India. I get the first prize. Later on, as it is not accepted worldwide because of deformity, as it is in the facial region. Like that, during my surgery, I have done so many things when I face a problem, but I cannot publish it. There is no facilities here. Few days back, I am going to doing a cataract surgery. And this patient is about 90 years away. When I am going to capsulorhexis, I see there is dialysis of the jugular ligament. Then it is a pain case. What should be done? I cannot raise the IOL in the posterior chamber. And what I did, I cut the haptics of the intraocular lens. And there is a board that I can show you. I shortened the lens by cutting the haptics. Then I put it in the iris. That is iris fixation lens. I make it iris fixation lens, but I have got no lens at my hand. I make it iris fixation lens and give it them to the chamber. What you did, patient's visual acuity 680, very good vision. Like this, we are doing so many things, but it should be published so that it will be lesson for our juniors. they can learn, and they will, when they will face the problem, they can solve the problem and then come out. With these two things, I want to establish the importance of CME. I like very much if you attend the CME just time, and we should finish at the just time, so that it will be there will be no hamper in our work. Our patient will get their service, and they will be benefited with our new knowledge. With these things, thank you all.
Sorry to again interpret with you. I took only 1 minute for just to inform everyone. And from today's decision, we are started CME from the next month, that is January, twice weekly. That is 2 CME in a single month. One will be held at the Tuesday and another will be held at Wednesday. Because of we have some academic problems, and from July I expected the CME will be carry on as like mock bazaar, that is every weekly. That is 2 cases or 2 CME should be carry on Tuesday, and 2 cases or 2 CME should be Wednesday. And another good news for you, that by this time we are a committee should be selected, and also this committee will be recognized by me. That is ethical committee and research committee. And don't see behind, see in front. I am started research here after performing or constitutes this research committee, and my research committee member are my departments. And by this time I access to the registrars of medicines and also the community medicine Dr. Bulbul. I started, and my topics is post-dengue syndrome, that is post-dengue arthritis in our hospitals or in Dhaka city. So do not, you are shy feel, you are started every persons from your departments, not waste your time, just uses your time proper way. Thank you everyone.
ধন্যবাদ স্যার এবং ম্যাডামদেরকে তাদের মূল্যবান বক্তব্য এবং সুন্দর একটা কেস প্রেজেন্টেশনের মাধ্যমে আমাদের সবাইকে কিছু শেখার এবং জানার সুযোগ করে দেওয়ার জন্য। এই বলেই আজকে অনুষ্ঠানটি এখানেই শেষ করছি।